morning, professors and my fellow friends. I am Setthawut Suppiumlarp from Police General Hospital, and I would like to thank you, TOSSM, for letting me present in fellow lecture today. And today I would like to present an interesting topic and advances in glenoid bone loss measurement techniques, a consensus on updated methods. In patients with anterior shoulder instability, the glenoid bone loss more than 25% is called critical glenoid bone loss. And this is from a study by Burkhardt, saying that performing soft tissue Bankart repair in critical glenoid bone loss has 67% operation failure. Then it is recommended a bone procedure. Furthermore, there is a concept of the subcritical glenoid bone loss, more than 13.5%, that's considering the bone procedure in the high-risk patients. So we look back into the glenoid bone. It has an inverted pear shape with a circle shape on the inferior part and the bare spot at the center of the circle. Average human glenoid width is about 23 to 30 millimeters. So a difference only 2 millimeters is equal to around 5%. So the precise calculation is very important for treatment decision making. The most popular method for glenoid bone loss measurement, as still in the Campbell textbook, is the Sugaya linear method. This technique is to drawing a best fit circle in the inferior two-third part of the glenoid bone in the 3D CT. And to calculate the percent bone loss, we use the width of the missing bone and divided by the diameter of the circle and multiplied it by 100. And this method we use for the preoperative measurement as we use in today. But for the intraoperative measurement, some studies say that the arthroscopy is the gold standard, and we use the probe to measure the bone loss. However, there is some disadvantages. The arthroscopy requires anesthesia and cannot be used for preoperative assessment, and the bare spot cannot consistently located by the surgeon. Okay, so these are the introductions. And today, from my review for the 2024 update, we will answer these questions. What is the best modality and investigation? Is there any new measurement method or techniques? And shall we use the contralateral glenoid as a reference for measurement? And what is the most reliable method we have today? First, to answer the first question, what is the best modality? Let's look back into something interesting. When assessing the glenoid, we use X-ray including AP, glacial view, Gath view, and axillary views. But however, the West Point view has been studied by Itoi for quantitative measurements, and it was found that a 21% glenoid bone loss in cadavers is equal to just only 18.4% in West Point view. So it is not effective and accurate for using for preoperative measurement. But there is another X-ray called the Bernacle glenoid profile view, a plain film that have been studied and say that it is effective and accurate for glenoid bone loss measurement. Patient is abduct and externally rotate their arm. The X-ray is caudal tilt 30 degrees and parallel to the scapula. From image on the right, you will see 23.6% glenoid bone loss from Bernacle view is compared to 22.9% from 3D CT in the same patient, which is the value is very close. And the study concluded that this view is valid and reliable for glenoid bone loss measurement. But however, this study doesn't propose that this will be replacing CT, but for the preoperative measurement, they still recommend to use the 3D CT. And in addition to the plain films, other imaging techniques like 2D CT, 2D MRI, and 3D CT can also be used for glenoid measurement. But however, it is well known that the most reliable investigation currently is 3D CT. Many studies show that it has the highest inter and intra-observer reliability compared to other modality. And there's a few reasons for this. First, the 3D CT gives a very sharp and clear cortical contour. And the second, the 3D CT, we can rotate the image to get a true on-face view of the glenoid. But in recent years, articles from Arthroscopy 2018 and 19 published the use of 3D MRI to assess the glenoid bone loss, and the results show that the 3D MRI gives the equivalent result to 3D CT. And additionally, there's another modality called the 3D zero echo time MRI. And the studies have shown that this modality gives comparable results to 3D CT. As you can see the image on the right, the image A represents the 3D CT, while B, C, and D represent the 3D zero echo time MRI. And as you can see that the results are very close. And the advantages of using MRI is we can reduce ionizing radiation exposure and avoid additional costs from CT. But however, it may not be widely available to create a 3D images from MRI, and skilled technician is needed. So after the investigation, now let's talk about the methods we use for measurement. We usually divided all the methods into two groups. First is linear method, and the second is the surface area methods. There are many published linear methods, but the most common use is the linear method by Sugaya, as I mentioned previously. But for the surface area method, it directly measures the area. The two most common methods is the PICO method by Mr. Bowdy in 2005. They measures the area in 2D CT and by using the superimposed contralateral glenoid. And the other method is also from Sugaya area method, which measures the area in 3D CT using a base fit circle. Both methods require calculating software on each hospital PACS software. Actually, there are still many other linear methods, such as Griffith index or glenoid index. And this method calculating an index by dividing the height or by the width of the glenoid. Or other methods such as Bachelon method, which using the radius of the circle and the radius of the bone loss to calculate the area. Or the circle line method, which using the chord and angle of the chord and put into the formula to calculate the area. And there is also other surface area methods such as the Dumont arc angle, which is use the alpha angle to create a calculated area. But however, I would like to share some of the newer methods that have been introduced in the past few years. First, we have the anatomic concave surface area method that introduced by Laune in 2021. And this method has a principle that the inferior two-thirds of the glenoid is not only circle shape, but also has a concavity. So they use their special software to calculate the area of the bone loss. Or the ratio method that introduced by Mr. Lederman in 2022. And this method shows the relationship between the length of the bone loss in the green line, as in the picture, and the height of the glenoid in the red line. And they put this ratio into the formula and gives the bone loss percentage that's shown in the graph. Or the constellation technique by Mr. Shen in 2022, and this technique using the program to create a more accurate circle compared to the conventional base fit circle. And this program creates a circle precisely along the edge of the inferior glenoid and calculate the bone loss by their specialized software. But from what I have shared, this interesting method is new, but it still didn't gain much popular in the real-world practice. The linear and surface area is still the main debate method in the recent studies. So, which method shall we use? There's a study published in Arthroscopy 2015 says that the typical linear method we use is to calculating the area of a square as shown in image A. But our glenoid circle, the calculated area is often bigger than the actual area, as shown in the red region in the image B. So this study found that the linear method can have an overestimation error of around 4%. Then there is a clinical study that showed the same result. The study say that they studied on 28 real patients and found that average bone loss by the linear method was around 17.5%, while the surface method is about 12.8%. That's a difference around 5%. So this study concluded that the linear method significantly overestimated the bone loss when compared to the surface area. So let me summarize the pros and the cons of both methods. The linear method is easy to use and widely accepted in the practice and no need any special software. But it usually overestimates the bone loss and represents the deficit in AP width only. For the surface area method, it's more accurate of the percentage bone loss glenoid measurement and leading to the treatment decision making. But it needs special software to calculate it in any hospital APAC software, and it's not widely available. Apart from the method, there's a question that should we use contralateral glenoid as the measurement? A study published in 2020, researchers tried to find out if our both glenoid is it the same size. And a total of 46 cadaveric glenoid pairs, they measured the width, the height, and calculated the surface area comparing each side of the glenoid. And interestingly, there were many pairs give significant difference of the glenoid size. So this study concluded that using the contralateral glenoid in measuring the bone loss should be used with caution. And so since that, the recent studies tend to avoid using the contralateral glenoid, but using the best fit circle instead. Then we come back to the question, what is the best or most reliable method? A cadaveric study published in 2021, six holders with 13 glenoid defect with 6 scissors. The study found that the surface areas such as the Pico and Bachelon method has the high consistency and accuracy compared to other linear methods. And the result is aligned with this study by Min in 2023, involving 3 assessors, 125 images, and 3 methods. This study also concluded that the 3D CT with the area measurement has the greatest inter-observer reliability compared to the linear or circle line method. The systematic reviews over the past few years give the similar conclusion. And as in this study, they including 27 studies with 1,425 shoulders. The review concluded that the glenoid width and the Pico methods are the most widely used and reliable accurate techniques. And the systematic reviews in 2022 and 23 also say that 3D CT with the surface area measurement is the most reliable and accurate methods. So from all of my reviews, here we can answer these questions. First, what is the best modality of investigation? I think 3D CT is still the best modality, but it has comparable results to 3D MRI and 3D zero echo time MRI. And is there any new measurement method? Yes, we have. But a lot of techniques has been proposed in recent years, but it's not popular in practice. Third, shall we still use contralateral glenoid as a reference for measurement? The answer is no, and we recommend using the best fit circle instead. And the fourth question, what is the most reliable method? The linear method is still the most popular and widely accepted, but current trend and review keep saying that the surface area method is more accurate and reliable. And there is no ideal technique. It's all about weighting pros and cons based on your preference and practicality of where you work. Each method has its strengths and limitations. Thank you.
In the past, we used the method. We make decision like 20 or 25% to consider the soft tissue posture or the bony posture.
Yes.
So in your review, you point out that for the surface method, it's more accurate.
Yes.
And less estimation than the linear method, right?
Yes.
So if you use the surface method, it means that you're going to change the percentage of the point to make decision, or you just use the same number of the percentage to make the decision.
Okay, thank you. The question. Actually, this is also my concern because from my review from the Burkhardt study, the 25% from the heart study is come from the linear method. But I think if we still use the linear method, we can still use the 25% from Berghardt study. But if try to use the surface area method, maybe we should try to reduce the threshold. But now we are having the 13.5% that from recent study of the subcritical bone loss. And this study also use, they are not using linear or surface area method, but they using the different calculated methods. So I think there is no consensus of this question, but it depends on which method you use.
Thank you for a nice review. But I wonder a question, the difference between these two techniques, linear and
the surface area,
that affect the clinical. Do you have any information about it? About affect the clinical or change treat? Because I see 4-5% different.
Yes, it's effect because it depends on the threshold you have. Because this study say that, let me show you. So this, as seen in this study, they say that if you calculate with the linear method, it's equal to around 17.5%. But if you use the surface area, it's equal to around 0.8%. So this is quite a big gap of the difference. So if you use the threshold, that if this patient is go to around the threshold, it will affect the treatment decision making. Like if this patient is around 20, if you use the linear, it's 25. If you use the surface area, it's 20. So the treatment decision is also a difference.
Maybe you have any comment about the MRI?
The MRI?
2D MRI to measure, comparing with the CT scan.
Okay, thank you for the question. The 2D MRI, it's, now the recent study also say that the 2D MRI is quite inferior to the 3D CT. But if any hospital can have the 3D MRI, these studies say that 3D MRIs have the comparable result to the 3D CT. So I think 3D CT is more preferred than 2D MRI. But 3D MRI is also good.